Hello and welcome to the Spine Nerve Podcast. My name is Dr. Brian Joves,
And my name is Dr. Nicolas Karvelas.
and we are going to continue our discussion on acute radiculopathy. We're going to take us a little bit further out and not just be talking about acute radiculopathy, but talking about radiculopathies and different types of radicular symptoms in general. And we had approached last week the discussion about some of the treatment options, specifically thinking about epidurals as something that has been utilized widely to be able to help patients when they're dealing with pain coming from their back, radiating down their limbs. And we wanted to review a recent article, a recent review article that really looked at epidural usage and the studies on epidurals and how it does to be able to treat patients with different pain syndromes. So Dr. K, if you would be so kind as to introduce this article for us.
Yes, definitely. And what we'll try to accomplish today is to review the article relatively quickly because I want to leave a little bit more time at the end for discussions. And as I've mentioned before, I had the privilege of being a junior resident with Dr. Joves and have learned a lot from him over the years, and definitely look up to his knowledge and skills from an interventional spine perspective. And so one of the things at the end here, we'll talk about some of the common clinical presentations of patients, from a low back, lower limb pain perspective. So, obviously, as we talked about in our previous podcast, when we introduced acute lumbar radiculopathy, we talked about how disc herniation, being the most common cause of that acute radicular pain. So, that's one thing that one of the common clinical presentations we'll address is radicular pain, but we'll also talk about how we approach pain more due to lumbar central stenosis, as well as post-laminectomy or failed back, or pain after a lumbar spine surgery. And then lastly, axial low back pain that we feel after our workup is due to discogenic pain. So those 4 different scenarios we will offer how we clinically, and not to say that is the way you should. It's, I think, part of the huge take-home point of this discussion today is that there is evidence out there. There's growing evidence out there. There's definitely, as we'll mention, some disagreement in terms of the different studies that are published. So it's important to, as always, take, as you've heard us say before, as you've heard me say before, the way we approach medical problems is what's the research out there, synthesize that as best we can. What's our clinical experience? What's the science behind it? Take those 3 things and make the best decision we can.
Yeah, and I think one of the really interesting takeaways from this is thinking about the way that people generally think about epidurals. I think, especially when I'm talking to patients or even a lot of referring physicians, they talk about, oh, an epidural worked for this patient, didn't work for that patient, when really the conversation should be the epidural worked for this pain pathology better than it worked for that pain pathology, right? And so, we do epidurals for a few different things, and every patient's different and every pathology is different. But even the science or the data behind why, or the outcomes from different pathologies with doing the same procedure or similar procedures is different. And so I think that there is a differentiation when we're thinking about approaching patients, and people thinking of epidurals as this kind of catch-all. I mean, it's a procedure, but kind of as a catch-all for pathologies, right? It's like, oh, well, they had back pain, they had an epidural, it didn't work. It takes away the diagnostic component of what we do before deciding to make an intervention. And so I think that's important because it's very hard, because you don't necessarily want to think about a procedure purely based off of just the outcomes that people see in commonplace without understanding why you were doing it, what it was, what the pathology was, what everything else was beforehand to lead up, right? Because as many of my mentors have said, it's choosing the right procedure and the right patient at the right time to make that intervention for people to make that impact on their quality of life.
Yeah, well said. And so getting, like I said, we'll try to get through the article relatively quickly here. Just quick background, as we know, lumbar epidural steroid injections are therapeutic needle-based procedures. And at this point, image-guided, standard of care being image-guided to treat low back and or lower limb radicular pain. So obviously there's 3 different types of epidural steroid injections in terms of the approach: transforaminal, interlaminar, and caudal. Epidural steroid injections have been utilized to treat low back pain since the 1950s. And even before that, without the addition of steroids. The literature, as we brought up in the beginning, the literature regarding the efficacy of epidural steroid injections is not without conflicting data and opinions. And for interventional physicians performing the procedure, it is important to be familiar with this literature and combine, like we said, the research with clinical experience to make the best possible medical decision for each patient. So today we will review a recent systematic review and meta-analysis regarding the safety and efficacy of lumbar transforaminal epidural steroid injections. So this study, this was done by Dr. Helm and his colleagues, published in Pain Physician this year in 2021. The title was Transforaminal Epidural Steroid Injections, a Systematic Review and Meta-Analysis of Safety and Efficacy. So the literature that they reviewed was literature regarding transforaminal epidural steroid injections from 1966 to April 2020. So quite a range there. And the articles they looked at were assessing pain relief and function improvement as primary outcomes. And they required at least a 6-month follow-up time period to be included in their review. One thing I think was important to note when I was looking through all the different studies they analyzed was that there was only one study that they presented as having a true placebo. And I think you could even argue that the quote unquote placebo in that study, which was a study by Dr. Rahman and his colleagues in 2010, because they essentially did a transforaminal approach, and they injected either local anesthetic alone, local anesthetic with steroid, normal saline, or what they considered to be a placebo in this systematic review. They injected intramuscular steroid, local anesthetic and steroid. So, the intramuscular steroid, like I said, I think you could present an argument regarding whether or not that's truly a placebo, since we know there's going to be some systemic uptake there. But I think the take-home point of this is that, as often is the case, it's going to be beneficial to continue to study this topic and to create not just randomized controlled trials, but trials that have that more true control or placebo to continue to give us the best quality evidence. Now, the level of evidence for each one of these studies was graded utilizing the U.S. Preventive Services Task Force 5-point scale. So essentially, just as a quick reminder, level 1 evidence being evidence obtained from multiple relevant high-quality randomized controlled trials, in contrast to level 5 being essentially expert opinion or opinion of a large group of physicians or scientists. The review addressed and this is why I brought up Dr. Joves, and I will also discuss this in a moment, but the review addressed the efficacy of transforaminal epidural steroid injections for different pathology, including 1, radicular pain, 2, pain due to spinal stenosis, 3, pain after lumbar spine surgery, or essentially post-laminectomy or failed back syndrome. And lastly, axial low back pain determined not to be due to facetogenic or SI joint or myofascial origin. So essentially, what I won't go over the details of every single study and their methodology, but essentially what they found was for radicular pain, there was level 1 evidence based on their criteria, level 1 evidence for use of transforaminal epidural steroid injections. For pain due to central stenosis, there was level 4 evidence. For pain due to post-laminectomy syndrome, there was level 4 evidence for transforaminal epidural steroid injections. And for axial low back pain, it was expert opinion or level 5 evidence for use of transforaminal epidural steroid injections.
I want to interject at this point. Just, I'd be remiss if I didn't bring up one of my mentors' studies at this point. We're talking about radicular pain. And obviously we've talked about the electrodiagnostic evaluation and how we find it beneficial for being able to appropriately target patients' pain and help get better outcomes. One of my mentors, Dr. David Fish, presented an article that at this point was probably 15 years ago. Fish, you need to step up your game and start publishing again. But showing that patients who had findings on electromyography, EMG, and we were able to then follow that up with a transforaminal at the level of the electromyography findings, did significantly better with those transforaminal epidural steroid injections than patients that did not have any findings on that exam. And so, when we're talking about there already being level 1 evidence for radicular pain, and then we add in the electromyography exam and be able to say, okay, these are the nerve roots that are showing that there is nerve irritation at this area, we can provide significantly better outcomes for our patients.
Yeah, I think that's a really important point. It goes back to what we brought up in the beginning. What's the research? What's our clinical experience? What's the science behind it? And the reason I want to kind of reinforce what Dr. Joves just said is that, when a lot of times when we're dealing with these situations, and not necessarily acute lumbar radiculopathy, but, for a chronic pain patient or a patient that's been dealing with radicular pain for a long period of time, they may come to you and you look at their MRI and they have moderate to severe lateral recess or foraminal stenosis at multiple levels. And then when you ask them, the distribution of their pain, it's not uncommon. They'll say, well, my whole leg hurts, and we've talked about in the past how that pain can become more diffuse and difficult to localize as it becomes more chronic. And so clinically, I 100% agree, if when that patient comes in, they have multiple levels of significant stenosis. If you are able to pinpoint, what nerve roots seem to be the most injured, inflamed, irritated, then absolutely the consequent transforaminal treatment will have, that much more of an impact on a positive impact for the patient. So I wanted to bring up this next topic before Dr. Joves and I conclude by presenting how we would address each, different clinical presentation. And I want to simply present this because, we hypothesize that a lot of our listeners are either just starting to do these procedures or considering a specialty where they would do these procedures, and or, someone ordering these procedures. And so I think it's critical to remember that, and I know Dr. Joves has done a good job of putting this into words in terms of always having a healthy respect, even though we do this procedure all of the time, and it is considered a overall safe intervention, having a healthy respect of the anatomy, and albeit rare, in the literature, potential significant adverse outcomes. And so, just having a good strong knowledge and awareness of the anatomy, including the vascular anatomy and the different techniques available to us in terms of approaching that transforaminal space. So along those lines, based on the studies reviewed in this systematic review, there was no serious adverse events. The most common complication in these specific studies included in this review was just increased pain, which resolves spontaneously. That being said, we've all read the case reports or heard the, those more devastating complications in terms of significant neurologic complications for patients undergoing these procedures. And so one of the things that this article brought up was the consideration of the use of the infraneural or Camden's triangle approach, as well as the consideration of the utilization of a blunt tip needle, based on the fact that studies that have looked at that have showed a decreased chance of penetration of an artery and or a nerve with the use of a blunt tip needle. And like I said, I'm not here, and I don't think Dr. Joves is here to offer a strong opinion one way or the other in regards to these considerations, but I think part of where all this comes from is the fact that the vascular anatomy in the thoracolumbar spine is important to be aware of, obviously including the artery of Adamkiewicz, because that artery is the primary supply to the anterior spinal artery, which, if compromised, could lead to significant adverse outcomes. And there's incredible variability in that artery of Adamkiewicz. You'll see studies saying anywhere from T5 to L5 in terms of where it enters the foramen. And although typically it enters on the left side up to 70% of the time or greater, there can be up to 30% of the time it enters on the right side. So you have this huge range, both in terms of cephalocaudal and where in the thoracic and lumbar spine this artery could be entering. And you have this significant variability side to side. And then on top of that, like I said, we add the fact that it's so critical to the vascular supply to the anterior spinal artery of the spinal cord. So yeah, like I said, I just wanted to present that as information before we move on to our last part of this discussion here, which was simply, for the different clinical presentations, how each one of us would present it. So we'll run through these relatively quickly here. And sorry, I know I said I wanted to leave more time for discussion here, but I think we have about 5 or 6 minutes. And so, which should be sufficient. And so starting with lumbar radicular pain, I think as this, multiple studies have highlighted, and this systematic review has also highlighted, I'll speak for myself, but I think Dr. Joves is going to agree here that if someone has more of a radicular pain, especially radicular pain due to a disc herniation, that's a situation. If you think about your options, transforaminal, interlaminar, caudal, if possible, you're going to do the transforaminal approach.
Yeah. Yeah. And, I think that's very commonplace in the community. I think that all of the literature obviously points in that direction. Like we said, we've talked about our kind of workup process and the utilization of electromyography and electrodiagnostics in evaluating this. But, utilizing a transforaminal to specifically target that type of pain is, one of the best things that we do in terms of, dealing with the disc and nerve components of pain for patients.
Yeah. And this next one, I think, is probably where we may have the most discussion. So for pain that you, based on your workup, believe is due to central stenosis. So my personal approach, which may, I actually will be interested to see what Dr. Joves says here, but my personal approach is, if I believe that, the primary pain generator is lumbar central stenosis, then I'll do an interlaminar approach one level below where the stenosis is the most severe. So theoretically, if they have 4-5 advanced central stenosis, then I would do an L5S1 interlaminar approach. And, obviously that's based on clinical experience, but also there's some literature, albeit, like as we brought up, there's definitely conflicting data out there. But, one study would be the study by Dr. Manchakanti and colleagues in 2015, published in Anesthesia Pain Med. Essentially, it was a systematic review, which we know systematic reviews, meta-analysis are not without their limitations either, but a systematic review that essentially looked at these epidural steroid injections for lumbar central stenosis, caudal, interlaminar, transforaminal, and found benefit with all of them. But there was level 2 evidence for interlaminar and caudal approach and some better data in terms of long-term outcomes versus level 3 evidence with transforaminal epidural approach.
Yeah. And honestly, I feel like that does mirror, what I've seen in practice over the past 7 years of doing these procedures is that, when it is more central, when it is a little bit more vague in terms of where that, where the radiation is going down their legs, the interlaminar or caudal approach does tend to do a better job. I agree with you. I think, especially in my training, what we always looked at was, the level of most central stenosis, and then trying to go one level below that area. I will say also, though, in those settings, there is really good data looking at the use of electrodiagnostic evaluation in those settings. Specifically, central stenosis can cause active findings in the lumbar paraspinal muscles, and which I think will help to, it has shown to be useful in predicting the outcomes of not only our interventions, but also the need for surgical intervention at some point, because those nerves are being irritated enough. And if there is a differentiation based off of that electromyographic examination, I have seen patients that respond better to transforaminals, even though their setting does seem to be much more of a central process or an urgent claudication type of process. And so, obviously this is the art of medicine. These are the areas where we have data that supports all of these interventions. And some patients just don't fall into the camp of, one thing for all patients. There are times where you have to try a couple of different routes to be able to find the appropriate management for that particular patient. And so thankfully we have the tools, like you reviewed the safety. Thankfully, the safety profiles, I think, are in favor of the interventions that we're making. And, we have ability to help a lot of patients in a lot of different ways.
Yeah. So just real quickly to wrap up here, for post-laminectomy syndrome, the only thing I would say, and obviously I'm still young in my career, but, I do feel like, especially after an extensive surgery with significant hardware, there is quite a bit of new bone that forms, scar tissue that forms, and also I feel like neovascularization, which has, I'm still developing my specific approach and how I want to, approach each individual patient. But I'm definitely I will do it, but I'm definitely cautious with that transforaminal approach in a post-laminectomy situation. Especially obviously at the levels that have been intervened upon surgically, for all those reasons I brought up. In terms of the ultimate flow that you get of the medication, the increased vascularity that seems of the area, and the development of new bone scar tissue. So the caudal approach definitely can be helpful. Obviously, interlaminar you can't do at the levels there's been decompression, laminectomy, hemilaminectomy, because there's been compromise to that ligamentum flavum. So the caudal, that's probably one of the most common times where I will utilize that approach.
Yeah. No, I think those are all things that have to be taken into account as we're trying to make sure that we're, working towards efficacy, but first and foremost, thinking about safety for these patients. And so I think this was a really nice overview, to really think about, overall, they did a pretty good job with this review, kind of addressing the idea of one intervention for multiple pathologies. The data, is, obviously we believe in the favor of utilizing these procedures. And most importantly, for everybody who's thinking about these options for patients, getting ready to perform these for patients, that anatomy, like Dr. Karvelas was talking about, that anatomy is not it's not 100%, right? As much as we believe all the anatomy to be what we believe it to be, there is a variability amongst patients and people in general. And so we have to be aware of those options, thinking about the different ways that, particularly the vascular flow and honestly where the nerve root is too, right? Obviously that comes into play when we're thinking about these approaches and needle placement. And so respecting that anatomy, being careful of the way that we're trying to intervene for people. But at the same time, understanding that these are procedures that can be very beneficial for so many of our patients.
Absolutely.
All right, guys. If you have any questions, comments, or concerns, please reach out to us. Stay tuned for those legal disclaimers. And if you're listening or watching to this point, did Dr. Karvelas and I still need to wear masks? We actually had this conversation first. We're on March 19th. The CDC has said if you're both vaccinated in the same room, you can take masks off. We're still recording with masks on, which I think it makes my voice sound worse. Anyways, everybody, have a great week.